Okay. Okay, Annie, do you prefer to have a pillow under your shoulders?
Yes, please.
Okay. I'm going to put a pillow here. And here. And pillow here. Are you comfortable?
Great, thank you.
This table is a little bit still higher for me because for doing some of the joint mobs, I prefer really lower table. Especially for this one because I do it in a specific vertebral range kind of way. So I'm going to try to show you like two different ways. We can do it in specific.
Do you want to show them on that thing before you apply it on me?
Sure, you can relax.
Yes.
Okay, so
you can
let's
lay that on top of me if you want.
Yes, please.
Sure. Whatever you say. There you
Fits
go.
perfectly.
Fits
Yeah.
perfectly.
That is kind of creepy.
Okay, what? Stay in place.
Can you give me a hypolordosis on it?
It is hard to do that. Okay, there.
Oh, yeah. There we go.
Relax. Okay, so what we are going to do is to do a PA glide, right? Posterior to anterior glide. So how I usually do it is by holding in between, to both sides of the SPs or like kind of in between TVP and SP, and then hold it on a specific vertebra and then stabilize your wrist and then move forward like that, 2 oscillations. That's how is the specific vertebral level PA glides. But we can also do it in a general way, like you can hold your hand like that, keep this thenar and hypothenar eminence here on the inferior portion of the spinous process, and then you are kind of putting pressure with these two sides like the thenar and hypothenar eminence here, and you can kind of like put a pressure like that, kind of opening the what?
What's that?
The segment?
I don't know, what do you say for that? Like opening the cap? I don't know. Whatever that is. So like this, and then do this way of light. No, like just putting a superior pressure like this. Yeah, kind of scooping. Yeah, that might be the word. So the thing is, you are putting pressure with your hypothenar and thenar eminence here instead of like going really specific into a vertebral level. You are kind of doing it in a general way.
Okay.
Does that make sense? Does that make sense?
Mm-hmm.
Okay. Okay, so let's do it on Alni now. So the first thing is you might need to do some of the Swedish techniques or like whatever to release those muscles around, because sometimes it might be hard to find the spinous process or the place where you actually want to do the joint mobilization. So you can also like do some fascial work, and then especially in case of hypolordosis, you might want to also like do some of those distractions and stuff like that, and then what else you would do?
Just the decompressions. Maybe
Yeah,
tilts.
decompressions and tilts and stuff like that, but we explained already. So after doing those things, I would try to find a specific level of L spine. And can I actually raise this one because it's too big? Okay, so I would find a specific vertebral level.
Probably
and-
upper L spine.
Sorry,
Upper L spine.
upper L spine. Okay. Actually, your spine is so easy to palpate.
I know.
Okay. Do you feel pain on here?
It's not great.
It's not. Okay, so I'm going to do it on this level. Let me do first my way. so I usually hold it on both sides of spinous process. Again, this table is too high for me, so I have to like do this, but that's not the greatest way for a therapist to do it, so it's better to have the table down. And then I usually stabilize my wrist because it's not really great for your wrist, right? So just hold it there and then kind of go take a deep breath in and breathe out. Then you do oscillations like that. So you could go like that, or you can also do like oscillations like that. Which one do you prefer, darling?
For the slow oscillations.
Oscillations?
The slow ones, yeah.
Slow oscillations? Okay. Deep breathe in and out. Is this good? Okay. Breathe in and out. So this is the specific vertebral level PA glides. And then if you want to do like general PA glide kind of thing, then you can hold on to the vertebral level like this, and also like kind of put pressure with the thenar and the hypothenar eminence. I don't usually do it this way, so I'm not the greatest to show it, I guess.
It would be easier if you were in the upper L spine.
And you are kind of applying a pressure like this, coping kind of pressure, along with the pressure with both these eminences. So while she's breathing in and breathing out, I'm kind of applying a pressure like this and posterior to anterior. Okay, take a deep breath in and out. Is that okay? Is it too painful?
Nope.
Okay, breathe in and out. Good? And breathe in and out. Does that make sense? So you are kind of putting pressure with your both sides of the palm, and also like doing a little bit of the scoping kind of movement. Is that right? Okay. So those are the two varieties to do that. Again, I usually do it on specific levels wherever I think it's needed. And again, it's for extension. So when the person has hypolordosis, it might help to increase that extension.
Which pelvic tilt are we going to recruit with promoting extension?
Anterior.
Anterior pelvic tilting. Yeah. So I will show you guys on our lovely little skeletal model, sort of the mentality of applying it generally and then applying it specifically segmentally. In some cases, individuals, you guys have seen my x-ray where I have one segment that's just drifted backwards. So we would do that direct mobilization to that one segment of mine. But individuals who are experiencing a full decrease in their lordosis, it would be beneficial if you do a general, specific, general. What does that sound like? Principles of massage. Oh my goodness. And then I'm going to show you with Anjali, very, very briefly and very gently, because she doesn't need them, how to utilize the P to A glides with the pelvic tilts to also encourage more activation of those muscles. So I'll show you on here first. Do you want to fall asleep?
Yeah.
Okay. Okay, and we just traded places, same consent applies. Correct? Correct?
Yes.
Okay. Just checking. Shoulders. Thank you. I'm set. Thank you. All right. So, our lovely spinal model here. This is a tall table. Damn it. All right. Yeah, I know. I'm sorry. So you will notice that with a lordosis, when there is the vertebral segments that need to be addressed, it's less so with the L spine than it is the T spine, but something to keep in mind. The reason why I wanted Anjali to show you that sort of like almost that scooping motion, almost like drawing a letter J, if you will, with your palm. You can also do that segmentally as well too, because even though they are closer, the TVP with SP, there's still a little bit of a hook onto the vertebrae below, right? So that's why applying that anterior glide with a little bit of a lift helps to create space segmentally as well too. Okay, so the way that I personally would apply this in practice is generally, because that's actually how I feel to see what the contour of the lordosis is like. I will just feel over top, see what things are doing. When I find that there is a decrease in lordosis, as we see a lot of people are flatter in the upper portion and have that dramatic incline at the bottom, I would probably start at the top, broadly, generally with their breathing. Nice breath in, Anjali. And encourage with breath out, almost like an anterior glide with lifting. I'm not going to actually do it because this is not a person. And then forward and up, just gradual sort of creating space and then encouraging that increasing in lordosis. Once I've done a couple passes, maybe up or down generally, that's when I will go through and apply that technique in a J stroke motion to glide it anteriorly, create space. Anteriorly create space. Okay, I would go through and do segmentally along the segments that need to be addressed, and then I would go through and feel gradually broad again to see if it feels more equal and balanced. Now, to help encourage utilizing pelvic tilts, I wouldn't suggest you do this in like board exam situation. You could, but just make sure you do it right is my only suggestion. But this will be really effective in practice when you have a patient on your table who you're trying to increase their lordosis. I'm gonna stand on this side because I'm right-handed. I'm not gonna block your view, hopefully. But essentially, when you go and apply that load through lift, that loading inwards and lift, that J stroke or that scooping motion, once you hold it in place, you can get your patient to anteriorly pelvic tilt to encourage an activation of those tissues and then let go. So to encourage increasing the extension motion of the upper L spine versus the lower L spine, to target the upper L spine, what motion would we ask our patient to do to encourage extension motions of the upper L spine? The shoulders and neck. So you get them to just lift their head and lift their shoulders, and that will target more the upper L spine. If it's in the lower L spine we want to target, we will recruit our pelvic tilts. Does that make sense?
Yeah.
Okay. So with Anjali, I'll pretend she actually has her hyperlordosis is very much, her lordosis is a J, right? So we can actually use this for her upper L spine. So I'm gonna go ahead and actually apply that. Is it all right with you, Anjali, if we go ahead and do that? Awesome. All right, so this is the left hand side. Can we turn the table around since you're dressed? Is that okay? Mm-hmm. Yeah, let's get you to gently, slowly remove yourself from the table. And we'll just turn the table.
We should pick her up with the table.
Are you okay with just chilling?
Yeah.
Okay.
The boys.
Just chill. That's fine.
Get the boys to do it.
Grab that
Boys
side.
do it.
Why? I live too.
I didn't say you don't have to. It's a gentleman thing to do. It's.
I live too.
It is. I didn't say you couldn't.
It's from too.
I didn't say you weren't. I just said it's a gentleman thing to do.
Thank you. All right, that's way better because I would rather use my right hand. Okay, so again, I would once again just go through and see how it feels in lordosis. You can kind of tell mobility of each segment as well too, just with like a mini J stroke over top of it, and you'll be able to feel right away with Anjali. It's stuck, stiff, rigid, and then it goes down into more mobile segments, down into where she has that curvature happening. All right, so to encourage, yes, I would want to employ some element of distraction decompression. Nice big breath in and out. Good, you can even do an element of direct decompression with indirect decompression as well too to take up the slack. You can do a cross hand decompression like you're lifting the T spine off of the L spine. Nice big breath in and out. So I usually shift weight one direction, so I'm lifting the top off the midsection. And then secondly, I can shift, hold this one here, and I'm actually trying to push the bottom away. I highly suggest you do them two independently because then you can actually focus on the tissues rather than just a, hey.
Probably feels better.
Yeah, you can actually feel the tissues letting go when you do one side versus the other. Nice breath in and out. So that's helping with the fact that she has that sort of the hook of the J in this lower portion. So I'm gonna focus on decompression in here, and I'm gonna focus on encouraging her lordotic curve in this upper portion here. Okay, so generally, I'd apply a little bit of decompression, nice breath in, and out. And then using that broad hand, attach the broad hand, I would do that forward and lift, let go, Anjali, let go, let go, let go, excellent. And I would actually do like little oscillations in that sort of J scooping situation. I don't want to call it J scooping because that's a thing, right?
Yeah, it is.
Yeah. The J motion. Yeah, there we go. That's not an official term, by the way. That's just like I'm drawing a letter J is what I'm doing. Good. And once that feels like it's actually gotten a little bit of mobility to it, you could get your patient to lift their head because I'm in the upper L spine. Angela, I'll get you to lift your head, lift your shoulder, back down. Good. And we can actually do that in conjunction. I'm going to go ahead, decompress. I'm going to bring it forward and up. Angela, head up and shoulders. Good. Back down. And again, go ahead and lift. Head and shoulders back down. So if you are going to do this, you have to mobilize first, get them to activate after. If they activate while you're trying to mobilize, are you going to mobilize?
No.
Correct. So we want to mobilize first, get them to activate the tissues to basically like hold in that position. Does that make sense?
So as she was lifting her head, you were then
I was
pushing into it, or you
No,
already
I did it before.
You did it before.
So I
Okay.
mobilize,
That's what I was saying.
she
Okay.
lift.
Okay.
I back off, I mobilize,
And
she
then
lift.
she lift. Okay.
Yes. So it's almost like the muscles are trying to contract to hold the tissues forward, right? You could also do that with the individual segment as well too. And the only element that I would have done differently, or I just added on top of what Angelique showed you, is I personally, just because of my own biases, I prefer there being a little bit of a lift whenever anybody tries to push my vertebrae forward. It just feels like it's creating space, right? You okay, Angelique?
So you're doing posterior anterior anchor.
So I'm actually going and doing this repeatedly. So with mobilizations, it's multiple applications is key when you're just trying to encourage mobility.
It also doesn't look like you're shearing either.
Exactly. I'm actually trying to
Yeah.
lift.
Also, like in J motion.
Correct.
Individually, J motion.
Yes. And then after I did it specifically, I can go back and do it generally, and then that's when I can go in and feel that we've got a little bit more of a curvature in this upper one. I'm gonna do that a little bit lower, so it's a little bit more equal with the lower one. See if we can get a more equal curvature happening. And even now, just with me applying pressure, that stiffness and rigidity that I felt in those upper segments is already gone down. They're much more willing to move because there's a more equal curvature happening in her L spine. You okay, Angie? Good. I know. Good. And then to help with this, I'm gonna get you to, Angela, I'll get you to go ahead and lift your head and shoulders off the table nice and gently, and then tilt good and back down. And then again, go ahead, lift and lift. Good, back down, and go ahead and lift, back down. So it's a combination of encouraging the muscles to bring somebody with a hyperlordosis into extension with the P to A glides. So the P to A glides is just an element of trying to accomplish a specific goal, which is encouraging their lordotic curvature, okay? Which is in the case of a hypolordosis, which you might see with degeneration. Okay, so primary elements, traction, distraction, and encouraging whichever direction they need to go. Make sense? All right, does anybody have any specific questions about degeneration and what we're trying to accomplish?
How about the pelvic tilt, so the lower part, so just to help the patient do some anterior pelvic tilt?
Correct. Instead of doing the head lifts, they would be doing the pelvic tilts if you found that it was a little lower, they needed it. Yeah, you got it. All right. So any other questions before we have you guys off to practice? Oh. Okay, it is now, what time is it? I don't have my glasses on.